We've been hearing a lot about ventilators lately with the COVID-19 pandemic, but do you really know what a ventilator or a breathing machine does? Does being placed on one always mean the end? And what is it used for other than COVID-19? I'm Dr. Ty, and we will break it all down to you today in this episode of Black America's Health. I have with me today Dr. Nathan Lott, an intensive care unit doctor and a lung specialist, as well as Dr. Sherika Newman, a palliative medicine physician who works with improving the quality of life of patients who have serious illnesses. Thank you guys for both joining me.
You're welcome.
Thank you.
So what exactly is a ventilator and how does it work? Let's just start with the basics. Dr. Lott, you want to start us off?
Sure. So when you look at a person under normal conditions, breathing is a very ingrained response that we all do. Like, you have to breathe in, you have to breathe the air out. That happens all day. When you have certain illnesses where you are unable to do that, that is when a ventilator comes into play. A ventilator takes over the work of breathing that your body is not able to do. And it does that through a tube that we put into your airway so that we can get the air in and out safely.
Got it. And so what's the difference between using a ventilator for a temporary issue, let's say a bad pneumonia or a lung disease like emphysema, and being on a ventilator for maybe a more terminal condition?
It's a spectrum because each of those conditions can be terminal. But if you have what is felt to be a self-limited condition, and I'll speak specifically on pneumonia or an asthma exacerbation, the purpose of using the ventilator is so that we can control the respiratory system, your lungs, get oxygen into the blood, get carbon dioxide out of the blood, and maintain that while your lungs heal from the damage that occurs from the disease that they're suffering from. From a temporary standpoint, we do that for the time it takes for that healing to occur. Now, when a condition is terminal, that means that we do not feel that the person is going to survive, that the person is going to die. In cases where that is what we're dealing with, the ventilator functions still as a means of getting oxygen on the blood and breathing the CO2 off, but it is truly a life support mechanism at that point. Whereas before, it is supporting life, but isn't managing it completely. That's the best way I have to kind of just explain that.
Dr. Newman, when you think about quality of life, are there any things that patients or their families should consider when you're thinking about whether, if they're on a ventilator longer term versus the temporary?
I mean, I think that Dr. Lott hit something very important that we all have to think about, and that's entering into a terminal or irreversible state despite aggressive medical care. And ventilation, artificial ventilation, is considered an aggressive measure, right?
Yes.
And so when we talk about these aggressive measures in a terminal condition, it's very important for us to know, to what end, right? And to what end is quality. So what's quality for me? What's quality for Dr. Nate? What's quality for you? It's all different. So it's important that long before patients get to a terminal state, or long before they're placed on ventilators, that we have a dialogue with them about what's quality to them. So I ask patients, what is fun for you? What do you enjoy doing? What do you miss doing because of whatever the disease is, because of your pulmonary fibrosis? What do you miss doing? And we talk about that in context. If you were never able to do that again, would you want to be on this machine for a prolonged period of time, right? Some people are okay with prolonged artificial support indefinitely. Some people are okay with being vegetables on support. 90% of America is not when we do the studies, right? So it's good to have that in a context though, because to what limit is our true question around quality. So if I can't get liberated from this machine and able to still attend church, I don't want that machine. If I can't eat chocolate cake, I don't want the machine. Okay, what's also valuable to me, Dr. Sherika Newman, is someone needs to come and make sure that my eyebrows remain arched. So if you can't do that, then I don't want that intervention. So we have to talk about that context of things when we offer these aggressive measures to people, because a lot of times our patients nor their family can take data and make it information. And a lot of times we doctors provide all this data, and our expectation is for the patient and family to take that data, make it informative, and make an informed decision. Well, that's unfair. We want the burden off of us. We put it on them. I call that displaced suffering. You know, it's the family members who don't want to remove the machines because they don't want to miss their loved one. Well, that's displaced suffering. Your loved one is suffering so that you don't have to. Sometimes we as doctors do that too. We don't want to make that difficult decision, so we displace it to the family. So I think it's not just educating our patients in the community abroad about the machines and what they do, but how it impacts your quality. And that speaks to everyone's value stream and belief. So it's important to have that conversation. I think the second thing, and you know, Dr. Lott, you know, maybe you can talk about this better than I can, is there's a certain point when you're on these machines that you definitely have to go to a next step, which is called trach, right? So
Yes,
if
that
you
is
want
true.
prolonged support and you need a trach, we need to have that dialogue. So if I have families or a patient that says, yes, Dr. Newman, please resuscitate me if my heart or lung goes bad, or if my lungs get worse than this, I want to be on the machine. My next question is, would you ever want a tracheostomy? And that is a question you have to ask someone, because if they don't know to even think that it could go down that direction, and then on day 10, we started talking to them about it, they could have made a different decision 10 days earlier. And so I think that's something that also needs to be incorporated in the dialogue. What do you think, Dr. Lott? You probably have these talks a lot.
We do have the talk often. And for us, it often depends on the length of time that we're anticipating intubation. So, an example, I have a 24-year-old who comes into my intensive care unit. She has a pneumonia so bad that she ends up needing to be on the ventilator. I give her a good 10 to 14 days. Her body recovers. She's able to come off the ventilator. I don't have to worry about a tracheostomy. Converse, I have a person that has severe end-stage lung disease. They come in with an acute exacerbation of their lung problem. Their oxygen's low. We put them on the ventilator. They do great on the vent. They don't really get to the point where they can come off. Now, in my practice, when I have a patient that has really, really bad lung disease, I've had that discussion with them ahead of time, telling them, hey, you know, your lungs are this. If I have to put you on the breathing machine, you're not coming off. Would you be willing to have a tracheostomy placed so that we can ventilate you or put you on a machine that will do the breathing for you out of the hospital? And I've had some that are like, no, absolutely not. And I've had some that are like, you know what, I am alive. You know, I may not be able to go directly home, but I will be here and my family can come visit me. In cases like that, okay. But we do have that discussion with our patients, you know, about having tracheostomies placed, typically for those that we know have a potential for long-term ventilation, not usually offered or discussed for patients that we're considering for short-term intubation.
Right, and just to clarify, the tracheostomy is when instead of the breathing tube going in their mouth, it's going through the neck, essentially.
Through the neck, right underneath your vocal cords.
Got it. And so I think you guys bring up really good points. One thing I want to point out is that sometimes we don't have the luxury, right? You know, you guys work on the more critical side sometimes, and then I'm in the, you know, the ER setting. And sometimes you don't have the luxury of being able to ask the patients what they want. Sometimes you're 100% having this conversation with family members. And sometimes you're having this conversation with family members who haven't seen the patient or seen them at Christmas for years, right? So
Mm-hmm.
what do you suggest, you know, as we have the audience watching this, what do you suggest for people and their families to do ahead of time? Maybe they're healthy, maybe they don't have any chronic illness. Do you still suggest that people talk to their families about what they want or don't want? Like, talk to me a little bit about what you counsel
So,
your patients.
so you're speaking to what we call advanced care planning, right? It's something that I would want for my medical care in the future, in the advanced setting. And so it's important for everyone 18 above to have that conversation. And we have it, unfortunately, in the context, if you got hit by a bus tomorrow, what would you want for your health care, right? And so everyone should have that. You should say if you want to be on artificial support, that includes what Dr. Lott was talking about, the breathing machine. You should also talk about artificial feeding and nutrition with the feeding tube in your stomach. And you should also talk about whether you want long-term care, what we call LTACs, right? Where you have this prolonged rehabilitation, sometimes year, right? A year of rehab. So you should talk about those things when you're 18 and above. Now, what most states have enacted is what we call a POLST, a Physician's Order of Life-Sustaining Treatment, POLST, or most in some states, right? Those are reserved for patients that we know are either fragile or have a serious illness, and they are more detailed, right? And it is a physician's order, meaning if Dr. Lott, Dr. Gaines, Dr. Newman fill this out with the serious ill patient, we sign it. That order is executable across all healthcare settings, whether you go to the hospital, to the nursing home, whether you in your home. So those are reserved for patients that we know are very sick, so they can say, hey, I know I have esophageal cancer. No, I would not want the feeding tube, but yes, I would want IV antibiotics. So it's important to have those dialogues long before you need it. And the coalition in California put together a beautiful packet that I pass out all the time. It's called the Conversation Starter Kit, or the Conversation Project put it together, but it helps walk patients and families through this dialogue, because it's not something we typically have over Thanksgiving dinner, right?
Right.
I do, by the way, every family gathering, I repeat what I want for my end of life care or advanced care planning, but it's not typical. And so it's very important sometimes to just get a gauge of when I should have it, who needs to be present. Mm-hmm. And I always really push patients to understand that your proxy needs to honor your request. And so you should really pick someone who's going to honor your request. It may not be your spouse. It may not be your sister. Like me, I told my sister, you're not it. You would have me rotting on a ventilator. You can't be it. So it's important to pick someone and kind of have that dialogue up front. One of my friends, our common friend, he has me, not his spouse, because he knows his spouse will keep him on. So it's those dialogues that are important when we talk about advanced care planning. And that should be for everyone, anyone. And then once you experience something, you have the right to change your mind. I have one child that was on purpose. Okay, I changed my mind about having 4 kids after I had one, because I had an experience that I didn't care to do again. So everyone reserves the right to change their mind.
That's true.
That is true. I'll add on to that. It's important to have this conversation, particularly amongst our African American family members. I have had plenty of experiences where we don't talk about these things because it's considered taboo. It's considered like a jinx, or you're trying to wish something bad upon someone, when the reality is these conversations need to be had when the people who want their wishes to be honored are alert and can actually tell you they want to have done, and so that the family that is involved will also be aware of what the patient is going to want and how best to carry out those things. Choosing the right person, as Dr. Sherika stated, is very key, because if you know someone's going to just keep you alive because they're guilty that they didn't do right by you while you were alive, they're the ones that would be making that decision. So having these advanced care planning discussions ahead of time, putting someone in place that knows what your wishes will be, and also getting living wills so that your wishes can be honored or respected if there is no one that can affect it is very important as well.
Yeah, I think the social barrier to advanced care planning, the spiritual barrier to these dialogues are a major problem in our community. The emotional barrier. So it's interesting that I had not had this conversation, and I've been in the field over 10 years. I had not had this conversation with my mother until 2 weeks ago. And as skilled as I am in having the dialogue, it's different when you have to have it with your own loved one. And so I know the challenge of having these dialogues and then, possibly having to carry out someone's wish. But it's hard to think of someone's authentic wish without them ever telling you. So it's best to have it up front, so you know what someone wants and making sure that you can honor it on their behalf. Having the conversation does not mean you have a lack of faith. Having the conversation does not mean that it's going to happen. It means that death is inevitable. It's going to happen to all of us. And so it's important that we maintain our autonomy as long as we can, even when we can no longer advocate for ourselves. And I think once we put it that way, the population tends to get it, because all of us hate losing our autonomy. It's one of the biggest things that our geriatric population complains about. I can't do simple things like go to the bathroom by myself anymore, or I can't enjoy dinner anymore, or whatever. So it's losing the things we enjoy that we hate the most. So this is one way to maintain your autonomy and your wishes and your desires, even when you can't speak to them for yourself.
Absolutely. And I think the other thing too that I have seen a lot, again, in my setting, is when there's nothing in writing and someone has 5 children, or actually an even number, 4 children, and the decision is split, right? And no one can make up their mind as to what mom or dad really would have wanted. And then it causes strife amongst the family at a time when they actually need to be coming together, because no one's ever brought this up and no one has a clue. Everybody's guessing, basically. So I agree.
Kai, is that, so it's interesting. What we've seen is that most family members actually want the same thing, but outpicture it differently. So most people want what's best for their loved one. They want them to be comfortable. They don't want them suffering. But how they define that is very different. And then, like you touched on, the pecking order or the next of kin law for each state is different. For the state of Georgia, where I practice, is the consensus of the adult children. My God, have mercy on my soul. Because you can barely get people to consent on pizza toppings.
Very true.
More or less an end of life decision for a loved one. It is impressive. But what I have done is they have these things called Go Wish cards. And so I bring the Go Wish cards and tell them to pick out the 5 most important things. And you'll see that most people pick out about the same things that they want for this person. How it outpictures is the problem. And so that's why when I have that division, I go back to quality. Because most families' cultural identity is about the same, beliefs, values are about the same. So if you pull it back to quality, then they tend to get back on the same page. Not all the time. You're going to have someone that's surly, you're going to have someone that's demanding, you're going to have someone that's spoiled. But most of the same family members get back on the same page and kind of come together to make a decision.
Yeah, one of the things that I like to do when I have come to those types of discussions, I tried to couch it to the family that the reality is you're not really making a decision. This is not a decision you're making. You are just honoring the life, the legacy, and the dignity of your loved one who's in front of us that can't speak to me. You would know them a lot better than I do. So picture them getting up from their bed, walking into this room, sitting down and talking with us and looking back at themselves. And what would they say if they could see everything that they're going through right now? What would they say to do?
Mm-hmm.
Absolutely. So let's just bring this back really quick just to what's been happening lately, right? I think a lot of families who never had to think about this topic before, thankfully so, now we're faced with all of a sudden critically ill family members that maybe didn't have a chronic illness. So let's talk about ventilators from the standpoint of COVID. Why did we need ventilators so much? That's what we heard so much of, right? We're running out of ventilators and the states need ventilators. Why did we need ventilators of all things when we were treating COVID? Dr. Lott, you want to start us off?
Certainly. So by this time, if you really don't know what COVID is, God help you.
Mm-hmm.
But it is a respiratory virus, meaning that it infects the respiratory system. What it does in a significant subset of individuals is cause a disease that essentially is just a huge inflammatory response within the airways. Not the big airways that the air travels through, but the really, really small ones where all the oxygen exchange occurs. Because that inflammation gets all the way down to those small airways, the damage makes it really, really difficult to get oxygen onto the blood. So no one knows truly what makes one person become that inflammatory reaction, and some people just have what they feel like is just a really bad cold. So because the early data coming out of China, Italy showed such a massive illness that caused a lot of people to become extremely sick and needing to be on the ventilator, that is why there was such a big push to get ventilators here in the United States. Now, in the U.S., while certain localities have had worse disease than others, the concern for the need is still very, very present, and that's the concern that everyone is having.
But what does the ventilator itself do for COVID? Does it open up the airways? What is it? Can you break down what it actually does?
The layman's way of describing what it does is it provides support and allows for the inflammatory reaction within the lung to resolve if it can. There is a high percentage of patients that need to be on the ventilator that don't survive when they have COVID.
Mm-hmm.
But some do, right? Some
there are
have
some
gone
that
off
do.
the ventilator, and
there are certain comorbidities that, when they occur in conjunction with the respiratory failure that cause them to need the ventilator, that puts them at risk for death. But some patients just have respiratory difficulty, some difficulty with oxygenation, but are able to overcome that.
So basically the machine is kind of breathing for them while the lungs heal. Is that a
Right.
fair way to describe it?
That would be the easiest way to describe it.
Got it. Dr. Newman, anything to add on that?
I just think that because we have realized that this is such a mass inflammatory response, there's a lot of damage to, or not damage, but definitely interference of your blood vessels and how they work. And part of that gas exchange that Nate is talking about happens between those little tubes down in your lungs and the blood vessels that run beside them. And so that sometimes, for whatever reason, the struggle we are seeing in patients that we're not able to liberate or get off these machines, that something is happening at this blood level, right? And the respirator or the ventilator helps the lung, but we don't have any help for those blood vessels going to that area. And so if your blood vessel going to the area is damaged, then even though the machine is out here trying to put gas in there and exchange the gas, if that vessel's damaged, then the ventilator may not help.
No exchange that can occur.
There's no exchange. Thank you, Nate. So that's the struggle we're seeing. And like he said, who it happens for and who it doesn't happen for, we are not sure. We know that patients at risk, at higher risk, are those with diabetes and high blood pressure, and even some other systemic problems. But the things that we thought were going to be problematic, like patients with asthma or some other lung disease, they tend to do better. And so we realize that this blood vessel damage that COVID is causing is really problematic and so foreign and unknown still, all of these months into this pandemic.
There's postulation that it is related to basically microthrombi into the capillary circulation. So we know now that part of the changes that occur, patients are more thrombotic, so they have increased risk of developing blood clots that can occur in the legs, the lungs, and that damage also goes into the microcirculation. That's why children have been found to have been developing some rashes and stuff in their skin. I think it has to do with microcirculation, thrombi, or clots being formed.
Microcirculation, maybe the small vessels, the clots going in there. Got it. I mean, I definitely, one thing is for sure, that there's a lot that we need to still learn about coronavirus and COVID-19. But I thank you guys for coming and talking to us today about ventilators and end-of-life decisions. I think it's an important topic for our community. I'm sure we could go on for another hour about this. There's so much more we can delve into, but I think this is a start.
I've got 10 years of experience, and so yeah, of course.
Right. But yeah, I'm going to put a lot of the references down below this video that were mentioned today. So if you want to have the conversation with your family members, you can click the link in those packets and use that as a guide. Don't forget to subscribe if you want more Black America South content. And we wish you guys all a very safe and happy day. Thanks.
Thanks, everybody. Thanks, Dr. Ty.
Thank you.
All right. Good. Nice job. Yay.